Margaret is 74 years old, a retired librarian from Pennsylvania. For almost 6 years, she took her blood pressure medicine every morning without missing a dose. She trusted Dr. Sophia. She followed every instruction. She never imagined the prescription could become part of the problem. Then, about 9 months ago, her son noticed changes. Margaret, who used to water her garden at dawn and walk after dinner, was now spending most mornings in her armchair. She stopped meeting friends for coffee. She started turning down simple outings she once enjoyed. One Thursday afternoon, Margaret stood up from the kitchen table and the room tilted. She grabbed the counter to keep from falling. When her son checked her pulse, it was 48 beats per minute. At first, the family blamed fatigue. They blamed stress. They blamed age. But Dr. Sophia had never explained that her medication might be slowing her body too much. Then came the truth that changed everything. It was not aging alone draining her strength. Her medication was playing a larger role than anyone realized. It was pushing her body past what felt safe. She was taking one of the two medications most often prescribed for blood pressure in older adults, and that raises a question many seniors never think to ask. Between amlodipine and metoprolol, which one is safer for an aging body? Most people expect a simple answer. There is no simple answer. The truth depends on factors many rushed appointments never explain, and that is why we need to talk about this carefully today. Before comparing these medications side by side, you need to understand something important. Without that understanding, the rest of this conversation will not land the way it should. The way your body responds to blood pressure medication at 70 or 75 is not the same as it was at 45 or 50. This is not a small difference. It is a major shift, and most doctors simply do not have enough time during an office visit to walk through all of it. After age 60, your artery walls gradually become stiffer. They lose the flexibility they once had. That matters because systolic pressure, the top number in a reading, becomes harder to control. It is also the number most strongly tied to stroke, heart attack, kidney damage, and cognitive decline. But the changes do not stop with your arteries. Your liver, which helps process many medications, starts working more slowly with age. That means drugs can remain in your system longer and build up more than expected. A dose that felt harmless years ago can slowly become too much without anyone adjusting it. Your kidneys also filter more slowly. Your nervous system reacts less quickly when blood pressure drops suddenly. That is one reason older adults can feel dizzy when standing up too fast. And your heart becomes more sensitive to medications that change rhythm, force, or speed. That is the lens you need to carry through this conversation. A medication is not automatically good or bad on its own. It becomes safer or riskier depending on the body receiving it. And after 60, that body has changed in ways that deserve a different discussion. Let us begin with amlodipine. To understand whether it belongs in a senior's routine, you first need to understand what it does inside the body. Amlodipine belongs to a class of drugs called calcium channel blockers. The name sounds technical, but the idea is simple. Every time your heart beats, calcium moves into the muscle cells lining your blood vessels. That calcium helps those muscles tighten. When the vessels tighten, pressure rises. Amlodipine blocks some of that calcium from entering the cells. As a result, the vessel walls relax. They open wider. Blood can move through with less resistance, and pressure begins to come down. For seniors, this offers a major advantage because it directly addresses one of the biggest problems of aging circulation, which is stiffened arteries. That makes amlodipine especially effective for lowering systolic pressure, the top number later in life. Research shows amlodipine can lower systolic blood pressure and reduce stroke risk in older adults, especially when hypertension is uncomplicated. It does not need to slow the heart dramatically to do its job. Instead, it improves blood flow by relaxing the vessels themselves. That difference matters. It targets the blood vessel problem instead of forcing the heart to carry the whole burden. For many seniors, that means good blood pressure control without placing as much direct pressure on heart rate. But even that advantage requires careful dosing. In younger adults, doctors often begin amlodipine at 5 milligrams once daily. In older adults, many clinicians prefer starting lower, often at 2.5 milligrams, especially in frail patients or those taking several medications. That lower starting dose is not overcautious. It recognizes that the aging liver processes medication more slowly, and the body may respond more strongly to each change. The dose can be increased gradually if needed, usually over 1 to 2 weeks at a time, but only when the person is tolerating it well. Slow and careful usually beats fast and aggressive in senior medicine. Now let us turn to metoprolol. This medication works through a different pathway, and understanding that difference can change how you think about blood pressure treatment. Metoprolol is a beta blocker. While amlodipine works mainly on the blood vessels, metoprolol works more directly on the heart itself. Your heart contains beta receptors that respond to adrenaline, the hormone that pushes the heart to beat faster and harder during stress, exertion, or excitement. Metoprolol blocks many of those signals. As a result, the heart slows down. Each beat becomes less forceful. Blood pressure falls because the heart is no longer pumping with the same speed or intensity. Sometimes that effect is valuable. For seniors who have already had a heart attack, who are living with heart failure, or who struggle with certain rhythm problems, metoprolol can provide genuine protection. It reduces the workload placed on a heart already under strain. In those circumstances, metoprolol is not just controlling blood pressure, it is helping protect the heart from further stress. But that same heart-slowing action is exactly why metoprolol must be used with caution in older adults. Many doctors begin seniors on 25 to 50 milligrams of the extended-release form, sometimes even lower, depending on the patient. The dose is adjusted carefully, not rushed, and heart rate must be watched closely. Here is one critical rule. Metoprolol should never be stopped suddenly unless a physician directs emergency treatment. Stopping it abruptly can cause a dangerous rebound effect, with heart rate and blood pressure rising sharply. That rebound can trigger chest pain, rhythm instability, or a serious cardiac event. Now that you understand how both medications work, let us make it personal. Daniela, 68, a retired school principal from Indiana, had taken metoprolol for nearly 3 years. At first it seemed fine. Then the fatigue crept in. She woke up tired, and by noon she felt finished. She described it as walking through wet cement. Eventually, Dr. Sophia reviewed her symptoms and carefully switched her to amlodipine. Within 2 weeks, Daniela felt lighter and more like herself. But after about a month, her ankles and feet swelled so much she struggled to wear her shoes. She told her daughter it felt like trading one invisible cage for another. Daniela's story shows the central truth here. Neither drug is universally safer. Each carries its own side effects, and each body responds differently depending on age, health status, and other medical issues. Amlodipine's most common side effect is peripheral edema, or swelling in the feet and ankles. This happens because the medication relaxes arteries more than veins. Blood enters the lower limbs more easily, but fluid does not always move back upward as efficiently, especially under gravity. The result is pooling. It is often uncomfortable, sometimes alarming, and occasionally disruptive enough to affect walking or balance. For older adults already worried about falls, that matters. Some people also notice mild flushing, dizziness when standing, or occasional palpitations. Not everyone experiences these effects, but when they happen, they can reduce quality of life in very practical ways. Metoprolol has a different side effect profile altogether. Fatigue is among the most common complaints. Many seniors describe a loss of drive, a heaviness in the body, making simple tasks feel harder. Because metoprolol slows the heart, it can also push heart rate too low in some people, leading to dizziness, fainting, or unusual weakness. And in older adults with asthma, COPD, or other lung conditions, beta blockers may worsen breathing symptoms even when the medication is considered relatively selective. That does not mean metoprolol is wrong. It means the margin for error may be narrower in certain bodies. Now we enter one of the most overlooked dangers in senior healthcare, and it has nothing to do with a single prescription by itself. The risk of either medication depends heavily on everything else already sitting in the medicine cabinet. Most older adults do not take one medication. They take several. The average person over 65 often takes 4 or more prescription drugs every day, and many take more than that. One may come from a primary doctor, another from a heart specialist, another from a lung doctor. Each prescription may be reasonable on its own, but together, the interactions can quietly become a serious problem. Amlodipine is processed in the liver by an enzyme known as CYP3A4. That same pathway is shared by many other drugs, including certain antibiotics, antifungal medications, and some cholesterol treatments. Even grapefruit products can interfere with the pathway in ways that raise drug levels unexpectedly. When that happens, like swelling, flushing, dizziness, or low blood pressure, a senior may think the problem is simply getting older, when in reality the issue is a medication interaction hiding in plain sight. That is why a complete medication review matters far more than most people realize. Metoprolol carries its own interaction concerns. When it is combined with other heart-slowing medications, certain rhythm drugs, or additional blood pressure treatments, the cumulative effect may lower heart rate too far or push blood pressure down too aggressively. In some seniors, that leads to worsening fatigue, fainting risk, confusion, or falls. The frightening part is that these interactions are not rare. They happen every day in ordinary homes. They happen to careful patients who follow instructions. They happen because prescriptions are often reviewed one at a time instead of as a full picture. When no one steps back to see the whole list together, dangerous patterns can remain invisible. So, what do major guidelines suggest? This is where clinical evidence meets real life, and the answer is more nuanced than most people expect. The American College of Cardiology, the American Heart Association, and other expert groups all emphasize that blood pressure goals in older adults should be individualized. For many healthy seniors, a systolic pressure under 130 may be reasonable, but for frail adults, people with multiple illnesses, or those prone to dizziness and falls, a less aggressive target may actually produce better outcomes. Lower is not always safer. In some bodies, pushing numbers down too hard can create new dangers. This is where the difference between amlodipine and metoprolol becomes clearer. Amlodipine is commonly treated as a first-line option for uncomplicated high blood pressure in older adults, especially when systolic hypertension is the main issue. It works well against the stiff arteries that so often drive elevated readings later in life. Metoprolol, however, is usually not considered the first choice for simple hypertension in seniors when no other heart condition is present. Its strongest value appears when there is another cardiac reason to use it, such as a previous heart attack, heart failure, angina, or certain rhythm disturbances requiring rate control. That distinction matters because it explains why one drug may be a smart choice for one person and a poor fit for another. If the main problem is age-related vessel stiffness and uncomplicated hypertension, amlodipine may make more sense. If the bigger issue is a heart that needs protection, rhythm control, or reduced oxygen demand, metoprolol may be the stronger option. The important point is this: a medication should match the diagnosis behind the prescription, not just the number on a blood pressure cuff. Too many seniors are given a drug without fully understanding why that specific drug was chosen over the others available. If that is making things clearer for you, remember this next part, because it may be the most useful section to carry into a real appointment. The question is not, which pill is best for everybody? The question is, which pill makes the most sense for my body, my heart, and my complete history? That is the conversation many seniors were never taught to have. Yet it is one of the most important conversations in modern aging. So let me answer the question directly. Between amlodipine and metoprolol, which one is safer for seniors? The honest answer is that neither medication is automatically safer in every situation. The safer medication is the one that fits the reason you need treatment, the way your body responds, and the risks created by the rest of your medical profile. Amlodipine is often a stronger choice when the main problem is high blood pressure, driven by stiff arteries, especially if there is no major heart condition requiring beta blockade. Metoprolol may be the better choice when a senior has already had heart damage, struggles with rhythm issues, or needs the heart's workload reduced. Safety is not just about the drug, it is about context. Without context, even a common prescription can become a poor fit. And knowing that is still not enough. The next step is learning how to speak up during your medication review. Too many older adults leave appointments with instructions but without understanding. So here are 5 questions to bring to your next visit with Dr. Sophia. First, based on my age and medical history, is this medication still the best option for me? Second, what side effects should I watch for, and when should I call the office? Third, has my full medication list been reviewed for interactions? Fourth, what is my actual blood pressure goal, and has it been adjusted for my age, symptoms, and overall health? Fifth, how often should we reassess whether this medication is still the right fit? And when might a lower dose or a different medication make more sense? These are not rude questions. They are wise questions. A thoughtful doctor will see them as partnership. Seniors deserve more than instructions. They deserve understanding, and families deserve to know what warning signs matter most. Now I want to take you back to Margaret, the retired librarian whose pulse had fallen into the 40s, while everyone assumed she was simply getting older. After that frightening afternoon, her son pushed for a full medication review. This time, Dr. Sophia looked at the complete picture. She reviewed Margaret's pressure pattern, resting heart rate, symptoms, medication list, and heart history. It became clear that the fatigue and near-fainting episodes were not random. Under careful supervision, Dr. Sophia began moving her toward a more appropriate plan. The transition was gradual, with monitoring, follow-up, and dose adjustments based on how Margaret actually felt. Over the next several weeks, her resting heart rate rose into a healthier range. Her dizziness faded. Her energy returned. She began tending her flowers again, meeting friends again, and walking the block with a steady pace her son had not seen in months. That was not a miracle. It was the result of asking better questions, reviewing the full picture, and making a decision based on who she was now. That is the lesson I hope stays with you after this video ends. Blood pressure medication should never be managed on autopilot, especially in later life. The prescription that seemed perfect years ago may no longer fit the body you have today. Your circulation changes, your organs change, your heart changes, your tolerance changes, and your medication strategy may need to change with them. This does not mean you should fear treatment. High blood pressure is still dangerous, and untreated hypertension can lead to stroke, heart failure, kidney problems, and memory decline. But it does mean your treatment deserves ongoing attention, not blind routine. It also means no one should ever stop, start, double, or switch a medication without guidance from Dr. Sophia or another qualified clinician who understands the complete picture. A change that helps one person can harm another if done carelessly. Even the best medication can become dangerous when taken in the wrong dose, combined with the wrong drugs, or continued after the body has changed. That is why self-advocacy matters. It is why family members matter, and it is why follow-up matters. When seniors, caregivers, and physicians work together honestly, medication becomes safer, smarter, and far more likely to support a strong and active life. So if you or someone you love takes blood pressure pills every day, do not settle for taking them on autopilot. Ask why this medication was chosen. Ask what it is meant to protect. Ask what symptoms deserve attention. Ask when the plan should be reviewed again. The right prescription can preserve independence, prevent stroke, and protect the heart. The wrong fit can quietly drain energy, weaken balance, and steal quality of life one day at a time. And the sooner you ask, the sooner you protect your energy, balance, confidence, and independence. This video is for educational purposes only and does not replace personal medical advice. Never change your medication without speaking to Dr. Sophia first.